Hi, today we're going to talk about the dynamics and the treatment of substance use disorders and the related comorbidities that come around with that in an older adult population. It's not news to anybody who's involved in any kind of healthcare or social services that when you look at the older adult population, the percentage of our population that falls into the older adult category, that percentage is growing and getting larger. That's been happening for quite some time. Sometimes it's referred to as the silver tsunami, and that's important because it impacts all of our social services and all of our healthcare services. And today I want to talk about the generational cohorts that we're identifying here. And there's really two major cohorts that are the older adult population today. Now, a question everybody has is, what's an older adult? What does that mean? What's the exact cutoff? And the reality is there is no agreed upon exact cutoff. But the literature, the scientific research, generally actually looks, when they're talking about older adults, they're looking at 55 and older. Sorry, I don't make up the rules. That just is typically how it is. A lot of times we think of older adults as being 65 and older because that's been traditionally an age of retirement, although that's changing a lot. But I know what the World Health Organization does is they recognize that older adults they're not just one group. And today that's very, very true. Today there is the younger, older adults, and then you have the older adults. These older adults, these are the good warriors. These are the people born 1908 to 1929. They're the World War II generation. They experienced things like the Great Depression. They experienced Prohibition. They grew up in a time where institutional authority was trusted. And that impacts how they view the world. But the larger group that is now becoming the largest group of older adults is the next generation after them. It's the baby boomers. These are people born between 46 and 64, and they grew up in Vietnam and sex, drugs, and rock and roll and civil rights. Institutional authority was to be feared or distrusted. And so that change is influencing how they access healthcare, including addiction treatment. Now, the trends that are happening now, what we're seeing in the new older adults are working longer. They're also living longer. They tend to be more educated than in the past. They are more likely to have a bachelor's degree than any group of older adults in the past. They are less likely to live below the poverty line. They're more likely to be divorced. And like with a lot of the rest of our population, they are more likely to have conditions like obesity. In fact, about 41% of older adults today have obesity, and that causes significant impacts on their health. But what about substance use? So, drug use of all kinds amongst adults 65 and older increased from about 19% of the population in 2012 to about 31% of the population of that cohort in 2017. There's a dramatic increase of use of all sorts of drugs, including alcohol. The number of older adults that are estimated to actually have problems with substance use conditions, so they need treatment, has been also increasing since 2000. In 2000, it was estimated that there were about 1.7 million older adults who would meet criteria for needing treatment for substance use disorder. That's now estimated to be around 5.7 million and continues to rise. But we have to ask two questions when I throw this out. And there's a first question that leads to it. And the question is, so what? The question that I often get is, as a therapist who works with older adults with addiction, is, so what? And I think that it's important for us to recognize that as a society, we tend to buy into two myths that are really important for us to challenge. The first myth is the myth of comfort in addiction. And I see and I hear it all the time. And an example, I saw there was a man who was an adult, and his father was 75 years old, and he was talking to a professional. And he said, look, my dad's the best. He's a great guy. He's been a great dad. He is an incredible grandfather. He loves his grandkids. They are more important to him than anything in the world. And he's always had a really active life, and he has been involved in the VFW every week, and he plays chess with guys at church every week. And then a few years ago, mom died. And he had always been a drinker all of his life, not a problem, but he started drinking more and more and more. And he eventually has developed alcoholism. And what that has done is that has made alcohol, the condition makes it the center of his world, so that everything eventually, playing chess with the guys, being at the VFW, all those things that were important to him eventually went to naught. And now he can't even enjoy being with his grandchildren. And this guy was saying to a professional, can you help me get my dad help? And the professional said this. He said, Frank, your dad is 75 years old. He's lived a good life. Let the old man have his booze. He's earned it. Let him be comfortable. See, this person, this professional, who, by the way, is a real story, and this was a really great, smart, caring, talented professional. But she'd bought into a myth that a lot of us buy into in our culture. And it's a myth that addiction is somehow comfortable in old age. And the reality is nothing could be further from the truth. In this man's twilight years, where his grandchildren and his relationships were more important than anything, those were being robbed because he had a condition where it was hijacking his brain and his ability. He could not fully engage. And he was losing those relationships. I want to tell you that at any age, true addiction is a living hell. And so in our culture, though, if someone that is younger has addiction, we know about it. They're not fulfilling their family obligations. They're getting DUIs. They're causing problems. They're not showing up at work. But if I am living alone and retired and I have addiction, it is out of everybody's view and it is out of everybody's experience. And so we as a culture tend to think and believe that it somehow is not a problem. But for the individual who is suffering from it, it is robbing them of everything. And so the first myth that we have to challenge is this idea that addiction is somehow comfortable in older age. The second myth, I call it the myth of discount people. And it is this idea that you can come to an age or a stage in your life, a point in your life where your ability to completely, fully engage, not just to live, but to have quality of life, is somehow less important. And so as professionals who are working with others, as health professionals in particular, it's important, it's imperative, it is critical that we challenge those myths. And so I come from a very strong bias that says that no matter who you are, no matter your race or your gender or your religion or your sexual preference or your age, every human being has the right not simply to live, but to the highest possible quality of life. And this is why treating older adult addiction is so important. And unfortunately, we have very little older adult treatment here in the United States. We're lucky to have one at Hanley Center. We're lucky to have this place in Florida. There are about 4 other places in the country. There are less than a couple of hundred beds when the need is in the millions. Well, part of that, the reason for that is that treatment of addiction, especially at a residential level, has been typically designed for young people, because a younger population, because we have tended to believe that addiction was only affecting the younger population. In fact, I remember when I started my training, and it was still said, it was said for a long time, that if a person had not developed an addiction by the age of 40, that they would not ever. And we now know that that is not true at all. When older adults do need treatment for substance use disorders, they come to the plate with different needs. And so it's important for us to understand those needs so that we can make sure that they're addressed. First, they come with different physical needs. Older adults who also have severe substance use disorders are statistically more likely to also have at least 2 other chronic medical conditions. And so treating older adults requires having the medical sophistication in order to make sure that their other healthcare conditions are not ignored. They're more likely to have significant physical impairment. And a really important key is that we'll talk about in a second here. As we age, our metabolism decreases, our bodies change, and the process of both detox and treatment takes longer. And that's something that's challenging for treatment programs and philosophies that are used to treating young people, and in the time frame that works for young people, it takes longer in older adults. And part of the reason for this, I said we talk about the changes in our bodies. So as we're aging, and this, by the way, by the time you hit around the age of 40, this has already started changing. So we get our bodies change, and we have less total body water, we have less muscle mass, we have an increase of body fat, and this decrease in total body water and other things is really important, because what it means is that our ability to metabolize drugs decreases, especially alcohol. And so the glass of wine that somebody has, a 5-ounce glass of wine at 20 years old, is different. It actually impacts the body differently when you're 50, and it impacts the body even greater when you're 70. And so that fact that our bodies are changing, whether we like it or not, want it or not, need it or not, it actually requires a longer time for older adults to recover. So they have medical needs that are different. Along with this, one of the common things that we see in older adults is chronic pain. One of the leading causes of death in the United States today is overdose of opiates. And many of these are prescription opioids that are prescribed, and had been for a long time prescribed for chronic pain. In the past decade, we have caught up with the reality that opiates should not be the first line of defense in chronic pain because of the risk of addiction that could lead to death. So what do? Do you simply ignore, if you have an individual who has the disease of addiction, and so it would be contraindicated for them to be on opiates, but they're struggling with chronic pain? What do? Well, one of the things that people sometimes do is they try to figure out how much pain is real and how much is just in someone's head. And that's a losing game. At the end of the day, all pain is real and should be treated as such. And at the end of the day, all pain's in our head too, because that's where we experience it. And so there are many ways. There's cognitive behavioral therapy, behavior modification, mindfulness training, meditation, yoga, EMDR, biofeedback, neurofeedback. I have a wonderful full list, and we can go through all of the rationales why all of these things have been shown to help people with chronic pain, as well as pharmacological interventions that do exist that won't exacerbate the addiction. The point is, they have different physical needs. We have to be ready to address them, including chronic pain, which should not be ignored just because we're not going to treat it with opiates. But they don't just have different physical needs, they have different psychological needs. So older adults entering into treatment are much more likely to have what I call the mirepoix of mental health conditions in older adult. The most common are depression, anxiety, and dementia. And so being able to, when we work with older adults who, especially if they've begun to develop symptoms of dementia, we'll take on dementia for a second. So they're starting to forget things, and people will often intervene and want to know, is this dementia that we're seeing, is this something that is because, dad's been drinking a fifth of Jack with, 6 Xanax for a day for the past 40 years, or is it something that's organic? And so when you're working with older adults, especially when there are questions of dementia, we have to be able to tease out what is substance-induced dementia and what might be organic. And so that means either having the neuropsychological services or having relationships with people who can provide the kind of assessment that they need to tease that out. And that also goes back again to the fact that it takes time. One of the things that we see is if it is truly a substance-induced dementia, when you give a person enough time off the substances, that dementia will start to clear. But going to depression and anxiety, there are a number of really relevant approaches: cognitive behavioral therapy, problem-solving therapy, interpersonal therapy. But I want to throw one thing out that has blown me away. And there's a 2014 study, and it was a really great comprehensive study. And what it found was this, that when older adults, and the cutoff for this particular study was 55 years old, when they engaged in the practice of physical exercise that included the mastery of a skill. So you can think about things like yoga, Tai Chi. There are chair yoga and exercises where we use rubber bands and teach them how to get better with very specific skills. Practiced physical exercise that includes the mastery of a skill is as protective against depression as an SSRI. It's as protective against depression as an antidepressant pill. That is really significant and should be something that if we're working with older adults, we should be doing whatever we can to have them engaged in some level of physical activity that includes skill mastery as an important part of their own recovery and being protective against depression and anxiety. The bottom line is, they have different physical needs, they have different psychological needs, and older adults have different social needs. The very first residential treatment program for older adults was started when the clinical director of an organization looked at their two programs. They had a men's treatment program and a women's treatment program. And every once in a while, they would have an older adult in one of those programs. And what this person realized is that when there would be an older adult, one of two things would happen. Either they would say, I don't relate to these guys at all. And they would sit and they would follow the rules and they would be quiet and they would do nothing and they would really not get much help, but they would be there and they would be quiet. And then they would go and they wouldn't do well after. Or they would become uncle, aunt, grandpa, grandma, dad, mom to the group, and they would be loved and they would help everybody else, but they wouldn't actually do any work on themselves. And so the research, there's very little research, but what the research on outpatient treatment had shown her was that actually older adults do better when they are getting treatment in a cohort, in their generational cohort. Why? Because their entire experiences are different, right? So they have their social status is changing. When I would work with groups of young people, there would be, sometimes someone would be in that group and they might have lost a loved one or a family member to death. All older adults, essentially, have had that experience of losing friends, of losing family, of losing loved ones. And the process of grief changes. The bottom line is that when older adults do treatment, when they do groups in their generational cohort with people who are having the same developmental issues as they are, they tend to be more successful after. They tend to do better. So, older adults have different physical needs, medical needs. They have different psychological needs. They have different social needs. And older adults have different spiritual needs. A study from a few years ago looked at what's called predictors of healthy adjustment to aging. This is another one of those points I find really, really important. And what they did is they looked at thousands of older adults and they asked them questions. They gave them several different surveys and made it into a tool. And essentially what they did is they asked them about their life, and then based on that, they were able to predict, to estimate how healthy these older adults were globally. So how well am I doing in my physical health? How well am I doing in my overall quality of life? How well am I doing? And they looked at all of the questions that were asked. And they found that one question, how an older adult answered one single question, was the most significant predictor of healthy adjustment to aging. So put real simple, I'm going to ask a whole bunch of people a lot of questions, and then I'm going to analyze it. And what they found out was that how those people answered one single question was the most significant predictor to whether on the other end of the day they said, I'm doing really well or I'm doing really poorly. Really digging life, really not. That one question, I think about it, and I'm a family guy, and family's really important to me. And so if someone said, what do you think is the most significant predictor of how an older adult's going to be doing overall in their life? I would say their relationship with their family. That's how I think, right? That's not it. A lot of people, I ask people this question, and what do you think is the most significant predictor of how an older adult is doing in their life? Globally. People will say health. Are they healthy? If they're healthy. That's not it. People will say, are they financially stable? That's not it. Here's the question. The question that is the most significant predictor of well-being in older age is, are you satisfied with your personal spirituality? That to me is really interesting, and it tells me something about my obligation as a therapist, as a healthcare provider. Now, what they found as they dug into this is that some people would say, I'm satisfied with my spirituality, and it was because of their religious involvement. Some people would say that it had nothing to do with any religious involvement. In fact, they weren't even religious. And what the researchers found is that it didn't matter. It didn't matter whether a person was religious or not religious. What mattered was that they had a sense of satisfaction with their personal spirituality. And so what that means is that providing older adults opportunities to explore that. It means that encouraging and providing what they defined as socially supportive spiritual practices. I remember once being told a long time ago that older adults would never go to 12-step groups. They would never go to AA or NA. They would never do those things. And what we found from our research over the years is that that's not true at all. that older adults are just as likely to engage the 12 steps of a group like Alcoholics Anonymous or Narcotics Anonymous. They're just as likely as young people. And part of that is because these are examples of socially supportive spiritual practices. They're not religious, but they are engaging the higher questions. They're engaging those questions that are about the things that matter to us, but are not things that we can hold onto or construct. And so young people, from a spiritual perspective, are tending to look for identity and purpose and meaning. They're on this road to defining who they are, to defining what life will be. In older adulthood, we're moving from pursuing success to pursuing understanding and significance. And so I'm looking back and I'm making sense. And one of the things that asking those bigger questions is, and the reason why having a socially supportive spiritual practice is that it helps reframe both the past and current struggles that people are having. So older adults, if we're working with them, if we're going to help them, first of all, we have to get over those myths. The myth of comfort in addiction. At no point, at no age, at no stage in life is addiction comfortable. And the other myth of discount people. The idea that one's ability to fully connect, fully engage in life somehow becomes less important at some point, at some age. We have to recognize that helping older adults who are suffering with severe substance use disorders and who need recovery as much as anyone else, they have different physical needs, they have different psychological needs, they have different social needs, and they have different spiritual needs, and we can help to meet those needs. At the end of the day, I want to take a second to specifically talk to anybody who is working with older adults. And I want to give you 5 questions that my experience has taught me, that especially the group of baby boomers, the biggest population of older adults that we have right now, here's what they want to know. Because I'll tell you that the earlier generation, that older generation, what they wanted to know is, what degrees do you have? Where'd you get? Is doctor in front of your name? Because if so, then I'll trust you. But the newer, older adults, they're a little bit different. They want to know this: do you respect me? And that means, do you treat me as an adult and as someone who is worthy, or do you treat me like a child, or do you treat me like a number? Do you respect me? Why should I trust you? With older adults, and I believe this is true with everyone, but in particular with older adults, it is important for me to always ask myself, am I being trustworthy? Am I making sure that I am keeping my word, that I am being transparent, that I am treating with dignity and respect? The next is, how can you help me? Why should I spend any time with you? The next is intertwined with that, and it's, how can we connect? The baby boomer generation is one that defined new levels of social connection that changed us, that changed our society long term. And so the question of how we connect is critical for the baby boomer in particular. Finally, Baby boomers and older adults are seeking from treatment. They want to know what to expect. They're not going to be satisfied with just being along for the ride. And so, do you respect me? Why should I trust you? How can you help me? How can we connect? And what can I expect from you? For those of you that are working with older adults, it's important before you begin the process to ask yourself how you will demonstrate your answers to those 5 questions. I hope this has been helpful, and I hope that it will inform more treatment for this population that so desperately needs it. Thank you so much for your time.